talk to you today about management of hypercoagulability in COVID-19 infections. Coronavirus 2019, which is known as COVID-19, is associated with a hypercoagulable state. And in many autopsies after in the post-mortem, they found many thrombi in different places in the body, including the lungs, the heart, the brain, even the kidneys. And this hypercoagulability is actually a distinct and different from DIC. We see in it increase in the fibrinogen and D-dimer, and also we find prolonged PT and APTT, and also for the platelets, it may be remain normal or with mild thrombocytosis or thrombocytopenia, on the contrary of the IC, in which we find very low platelets due to consumption in the clotting. Also, one of the interesting findings that lupus anticoagulant is common in individuals with prolonged APTT. The D-dimer is of importance because it is high in most of the cases of COVID-19, and actually they started to use it in research as a prognostic marker for severity of the disease and also for mortality according to its titer. It increased that there is risk of thrombosis, but also we should put into consideration that the dimer can increase in different other diseases like in heart failure, nephrotic syndrome, renal failure, and pregnancy, and also in severe inflammatory disease and severe sepsis, which is the case in COVID-19 cases. Also, we need to decide, when we need to decide about the anticoagulation, we should ask three main questions. Does my patient need anticoagulation or not? Second question, what is the level of anticoagulation needed? Is it thrombolysis? Is it anticoagulation at treatment dose? Is it prophylaxis? Or my patient needs no treatment at all? And third, very important question, is the balance between risk of thrombosis and risk of bleeding. So what is the risk of thrombosis versus risk of bleeding in my patient? Because if, say, for example, if I have very low platelets, I may not be able to prescribe any treatment. And also if I have a history of active bleeding or hemolysis, this may impair my ability to prescribe anticoagulation. So what are the key drugs we use for anticoagulation in our COVID-19 patients? First, it is low molecular weight heparin, like enoxaparin, clexane, enzaparin, inohep, unfractionated heparin, warfarin, and also for patients who shows HIT syndrome, heparin-induced thrombocytopenia, we can give them fondaparinux. Direct and oral anticoagulants can be used, but it is not actually recommended, but it can be used in case of patient cannot self-administer the heparin to himself, or the patient has problems with clexane. This algorithm is a nice algorithm published this year, 2020, in up-to-date, trying to facilitate the decision-making for anticoagulation. And we will go through this algorithm part by part to understand how the process of prescribing anticoagulation in COVID-19 works. So, first part of the algorithm, we ask ourselves the most important question: does the person have a documented or strongly suspected thromboembolism? So, we have one of two possibilities, either yes or no. So, if yes, first question, which is also important because it may be life-threatening, is there is possible ischemia or infarction, something which needs admission to CCU or to ICU for thrombolysis, like acute myocardial infarction, acute ischemic stroke? You know, we can do thrombolysis for patients with ischemic stroke in the first 3.5 hours. Is there massive PE, massive pulmonary embolism affecting the hemodynamics, or LEMP DVT, or arterial thrombosis with threatened ischemia? If the answer is yes, so in such case, patient should have thrombolytic therapy, not normal anticoagulation like warfarin or heparin. No, he is indicated for thrombolytic therapy like TPA, streptokinase. And in such case, he should be admitted to intensive care area and get the full thrombolysis. But if my patient doesn't have any life-threatening thrombosis which needs thrombolysis, so in such case, I will ask myself, is anticoagulation is appropriate for thromboembolic disease? If there is another thromboembolic disease like DVT or pulmonary embolism, not massive, which is not affecting the hemodynamics, in such case, patient needs the normal anticoagulation at treatment dose, which means to start with heparin, low molecular weight heparin, or unfractionated heparin if indicated, and then followed by warfarin as normal anticoagulation for DVT. So this happens if the patient has a thrombotic disease, either needs thrombolysis or needs anticoagulation full treatment dose. So I will not give, here is the point I want to stress on, that I will not give treatment dose of anticoagulation except if the patient has DVT or pulmonary embolism. And of course, will not give thrombolysis except if the patient has one of the conditions need thrombolytic therapy. So say if the answer is no, the person have no documented or strongly suspected thromboembolism. So in such case, the next question will be, is the person already taking an anticoagulant, like patients with atrial fibrillation who are maintained on long-term anticoagulation with warfarin or oral anticoagulants, or VTE, venous thromboembolism? If the answer is yes, in such case, the anticoagulation should typically be continued unless there is contraindication. Also, one of the things which sometimes suggested, if the patient becomes severely and acutely ill and hospitalized, is to switch him to a shorter acting injections, parenteral injections or heparin, to be able at any point to control the situation if there is further deterioration. But the general principle that if my patient who now is infected with COVID-19 gets COVID-19 and he is already on anticoagulant for a thrombotic condition, so he should continue the same management, except if he becomes severely ill, we can modulate it. Say, which is the case of most of your patients, the answer is no. So in such case, patient is not on long-term anticoagulation, patient has no thrombotic disease, needs full dose anticoagulation, no disease contains or needs thrombolytic therapy. In such case, the next question will be evaluation of the severity of the disease. So, does the patient have severe COVID which needs admission to hospital? If the answer is yes, so I will ask myself what is the level of care needed, because admission to hospital may be either for observation or ward care and ward-based management, or for ICU and intensive care. So if the answer is no, and the patient has mild to moderate COVID-19 and he can stay at home as outpatient, in such case, I will continue the anticoagulation if already taking, but if he is not on anticoagulation, I will prescribe prophylactic anticoagulation only if in selected patients if there is certain risk factors. So for mild to moderate COVID infections, I will not prescribe the prophylactic anticoagulation as a routine, but I will give it only to high-risk individuals. And we will talk now about how to evaluate the high-risk individuals. We will evaluate high-risk according to people who are at high risk of severe disease and at the same time have another high risk like the general population. And others actually don't need or require anticoagulation. This is very important to avoid exposing people to unnecessary treatment with anticoagulation and the risk of bleeding. For people who have severe disease and are indicated to be admitted to the hospital, so it depends upon the level of care. But we have a general principle that all hospitalized patients should have prophylaxis. So any patient with severe disease should have prophylaxis. So people who goes to the critical care, ICU, or any equivalent high dependency area, so anticoagulation is appropriate. But the level of anticoagulation here, if it is prophylactic dose or full treatment dose, actually is controversial due to the high risk of DVT and PE in patients with severe disease. And so this will depend upon the guidelines of the institute. But for people who will go to the hospital and will be kept in normal ward, we will use the normal prophylaxis, prophylactic dose anticoagulation. So usually we use the low molecular weight heparin, which is preferred, and we go for unfractionated heparin of the creatinine clearance is less than 15 or patient is on RRT, renal replacement therapy. As I said, fondaparinux may be used in individuals with HED syndrome, heparin-induced thrombocytopenia. This was the algorithm explaining how can we anticoagulate our patients. And so if we take home message, so mild to moderate COVID, there is no prophylaxis is needed except if there is risk factors for VTE or risk factor for progress to severe disease. And in moderate to severe, we should start thromboprophylaxis for our patients. And for inpatients, all of them should be put on thromboprophylaxis because this means that they have more severe disease. And if you have proved venous thromboembolism, DVT, or pulmonary embolism, please start anticoagulation treatment dose. And if you have proved MI or massive PE, admit to ICU or CCU for thrombolysis. Assess risk factors for thrombosis versus bleeding. This is very important. As I mentioned, patients with COVID-19 have higher incidence of thrombosis. They have also risk of bleeding. Patients may present with hemoptysis. They may cough blood. Also, they may get stress gastric ulcers if they have severe disease. Also, we have many patients with GI presentations in the form of diarrhea who are liable to ulceration. We have many of our patients who have liability for bleeding in patients with liver disease, liver cirrhosis, and chronic kidney disease. So we should be careful about this. So we should look at the risk factors in patients with mild to moderate disease, especially patients with congestive heart failure, patients with a history of previous stroke, old age patients, patients with previous history of thromboembolism, and patients who are not mobile and they are bedridden. And also we should keep an eye on patients who are progressing because they may start as mild and then proceed in a few days to severe cases. In such case, it will be indicated to apply the principle of severe cases and put them on thromboprophylaxis to prevent thrombosis. So it is very important for mild to moderate to look at this. So if you have high risk for progress to severe disease or you have a high general risk for thrombosis, you can prescribe. So they are the only selected patients, but otherwise no thromboprophylaxis is recommended for patients who has mild to moderate disease. So also you should assess the risk of bleeding to complete the balance. So because patient presentation, look at patient presentation, it may be hemoptysis or any other history of bleeding. In such case, thromboprophylaxis will be difficult to start. If you have other disease comorbidities like CKD or liver cirrhosis, you should modulate the dose according to the CKD stage. And also you need to look at liver cirrhosis and if the patient has also bleeding esophageal varices or very low platelets. So for this reason, check platelet count, check the PT and INR, check APTT, check D-dimer and EGFR. If platelets less than 30,000 or there is history of active bleeding, in such case, no pharmacological anticoagulation is recommended. Actually, it is safe to give pharmacological anticoagulation if platelets are above 50,000 cell per microliter. Between 30,000 and 50,000, there is no big evidence, but you can give pharmacological thromboprophylaxis if it is above 30,000, but the more safe is to be above 50,000. In case of if there is contraindication for pharmacological anticoagulation, in this case, you will use stockings and ask the patient to be ambulant and use pneumatic compressions to avoid thrombosis. If we go to the prophylactic doses of drugs, so the standard dose of enoxaparin is 40 milligram once daily, but it differs actually about the body weight. So if the body weight is less than 50 kilograms, we give 20 milligram once daily, subcut. If more than 50 kilograms, we give a standard dose, which is 40 milligram once daily. If more than 100 kilograms, we give 40 milligrams subcut twice daily. The other factor which affects the prescription is if creatinine clearance is less than 30 per minute, we give unfractionated heparin 5,000 twice daily, and we increase it to 3 times per day in case of malignancy or multiple venous thromboembolism risk factors, or if body weight is more than 100 kilograms. The reason of that is that there is evidence of accumulation of low molecular weight heparin in patients with renal disease. But also, if we use the prophylaxis with tenzaparin, which is Inoheb, we use it in hemodialysis patients without a problem at a dose of 4,500 international unit. Thromboprophylaxis doses increases if patients requires intensive care. So in such case, we give the enoxaparin at a dose of 0.5 milligram per kg. So as you can see, if less than 50, we give 20 milligram, but twice daily, which in total is 40 as the standard dose. 51 to 100 to be 40 twice a day, 101 to 150, 60 twice a day, more than 150 kilograms, 80 twice a day. So we increase the dose if the patient requiring critical care, because this indicates more severe disease, and the more severe disease is liable to have more thrombosis. There are other doses like tenzaparin, as I mentioned, prophylactic dose 4,500, and deltaparin prophylactic dose 5,000 international units subcut once daily. And in patients with heparin-induced thrombocytopenia, use fondaparin. Some suggest that heparin, why do we prefer heparin more than direct oral anticoagulants? So some suggest a benefit for heparin over oral anticoagulants. So in the Mount Sinai Hospital guidelines in America, they mentioned in their guidelines that heparins bind to COVID-19 spike proteins, and COVID-19 spike proteins are the proteins which usually bind to ACE2 receptor to enter into the cell. So heparin binds tightly to it, which may affect infecting the cells. Heparins also downregulate interleukin 6 and directly dampen immune activation. DOAC, direct oral anticoagulants, don't appear to have their anti-inflammatory properties. And it is of note that in this algorithm, they used apixaban 2.5 to 5 milligram once daily in this algorithm in exchange with the heparins. And also, they documented that rivaroxaban also can be used in place of apixaban in this algorithm. So they used the two of the direct oral anticoagulants in this algorithm in exchange with heparin. So in summary, the first preference is for heparin, and rivaroxaban can replace it. We have some important notes here that many antibiotics have drug-drug interaction with anticoagulant drugs, which may affect its serum level. So be careful and adjust dose according to this. Number two, for patients where there is either contraindication to enoxaparin or unable to self-inject enoxaparin injection, offer prophylactic rivaroxaban, which is only 10 milligram once a day per oral for people who needs prophylaxis. So we don't use higher treatment dose in prophylaxis, but only rivaroxaban 10 milligram. Avoid rivaroxaban if creatinine clearance is less than 15 mL per minute. It is important, it's contraindicated, because it's associated with higher risk of bleeding. And if creatinine clearance between 15 to 50 ml per minute, rivaroxaban dose should be adjusted to the kidney function, or if we are giving it as treatment dose for anticoagulation. And this can be calculated through calculating the glomerular filtration rate. So we should get kidney function test before prescribing the anticoagulation. Also, there is no evidence of aspirin or clopidogrel. Actually, aspirin is beneficial for people as primary prevention for ischemic heart disease and myocardial infarction. So if patient is already on aspirin for this indication, he can continue. But there is no evidence for aspirin and clopidogrel for the anticoagulation for COVID-19. This table is a certain score. It is a DIC score calculator recommended by the International Society of Thrombosis and Hematology. Okay, so you should, while you are monitoring your patient, if you find that this score goes between 5 and 8, so DIC is probable. So this score depends actually on platelet count and the rate of increase in D-dimer and prothrombin time prolongation and fibrinogen level. So if fibrinogen start to go down while it goes up in case of COVID-19, if the D-dimer increase is going up many folds, and there is a significant decline in the platelet count despite in COVID-19, we said usually we may have normal platelet count or mild increase or mild decrease. So this will attract your attention that your patient now is proceeding to DIC. A very important remark to say at the end that for patients who had severe COVID-19 infection and who are at high risk of thromboembolism, we should extend the pharmacological thromboprophylaxis for 14 days after discharge in the form of enoxaparin Kilexam prophylaxis or rivaroxaban 10 milligram once daily, which is a prophylactic dose of the direct oral anticoagulants. Actually, there is no good evidence to try to identify exactly who are the patients who are at risk of venous thromboembolism post-discharge, but this is important to prevent the mortality after discharge. So we extend the pharmacological thromboprophylaxis for 14 days to prevent this. So in summary, we should evaluate our patients we should evaluate those patients who have severe infarctions like myocardial infarction or massive pulmonary embolism who needs thrombolysis. This is very important. Also, we should evaluate patients who have current evidence of venous thromboembolism who needs anticoagulation at treatment dose. And we should put all severe patients on thromboprophylaxis. And for patients who have mild to moderate disease, we should look at the risk factors, and if they have risk factors, we should start prophylaxis. Of course, as we mentioned, patients who are in ITU will have a higher prophylaxis dose than those who are in normal wards. I hope this summary may help to facilitate the understanding and proper corrective prescriptions for anticoagulation thromboprophylaxis in patients with COVID-19. Thank you.